Good morning, Horst.
Good morning, everybody, and welcome to CVC.
Yeah, good morning. We can hear you and see you.
Can you hear me?
We can hear you and see you. Yeah, good morning.
Good morning. So now I can hear you. Good.
Okay.
So welcome to CVC. We have case number 3. With me is Markus Reinertz, and the TE will be done by Bobu, which is Bojan and Bushra. And we have the case history presented by Philip. Please go ahead.
Good morning, ladies and gentlemen. Our first patient today is a 71-year-old female with permanent atrial fibrillation. In October 2016, she was hospitalized due to Coumadin overdosage with a quick of under 10%, an INR of 7, and HB of 6.4 grams per deciliter, which made transfusion of 2 erythrocyte concentrates necessary. She had atraumatic hematoma on her right arm, both legs, and sublingual bleeding. Her current oral anticoagulation is apixaban. She also suffers from hypertension. Her ECG showed atrial fibrillation with a heart rate of approximately 87 beats per minute. TTE showed a dilated left atrium of 45 millimeters, a normal left ventricular ejection fraction, and mild aortic, mitral, tricuspid, and pulmonary regurgitation. Her risk scores are a CHED score of 1, a CHED VASC of 3, and a HAS-BLED of 5. And now back to Professor Sieber.
Okay, thank you very much. Any questions regarding the history or indication?
Any questions from the audience? No, nothing.
Okay. So then let's move.
They're still waking up.
Yeah, good. So I have a 6 French sheath in the groin, in the femoral vein. Bushra and Bojan are just doing some measurements, but Bushra or Bojan, can you give me
Horst,
just...
did you use ultrasound-guided access or the normal way for you?
Well, actually, that's actually a good question, because usually everybody thinks, well, venous puncture is easy, but it's not always. And here it was quite difficult, and Julia was about to go and bring the echo machine for the ultrasound-guided puncture, but finally I made it. So it's not always that trivial. Okay. Especially if you are a coronary guy, then it may be difficult. So, Bushra and Bojan, can you give me a short axis of the septum and the aorta? I would like to start with the bubble test. And the reason is that if there is a PFO, then I may consider to use the PFO instead of doing a transeptal puncture. The best way to rule out any intra-atrial shunting is short axis, 30 or 40 degree, and then just focusing on the aorta, because if there's any shunt, then you will see bubbles appearing in the aorta. So it looks like there is no shunt. Can she do a Valsalva? No shunt. Can you compress the abdomen or ask her to? Now she's doing a Valsalva. Okay, so there's no shunt. That means we will do a transeptal puncture. And now let's take over the microphone to Bushra and Bojan. Can you please explain what you see there?
Okay, so should we just start with the 3D, then we'll go through the systematic 2D images. So here's our 3D picture. And what we see here is, so just to give you some landmarks, this is just the edge of the mitral annulus. Here's the orifice, or the echo orifice of the appendage. And what you see is here, there's this top superior surface here is your Coumadin or warfarin ridge. And you can see it spirals down. And interestingly, it looks very shallow, this appendage. And what you see here already, before that there aren't obviously any deep lobes, just looking at the 3D. And you can see...
Bushra?
Yeah?
As Neil said yesterday, this appendage has a wide mouth, a narrow mouth and a wide sort of orifice. Is that right?
Absolutely right. It doesn't really seem to have
much... It's like
much...
Donald Trump's mouth, he said.
I think that's a very good description. So you can see here that there are a few very small, shallow lobes here. So it's already looking very interesting. So we're going to go to the 2D now. And we'll start in our systematic way. 0 degrees. And at 0, you get a glimpse of the appendage, but you don't always see it that clearly, but you can see it just coming into view there. So you can see it there, and that kind of confirms what we think we're looking at. So I'm just going to freeze it there. So what you see is that very wide orifice that is oval shaped. So in this view, it actually looks quite narrow, but we know it isn't. And then you see it moves down from the smooth neck almost, and then you get the trabeculations where the appendage starts, so where you'd expect. So the circumflex vessel is around this level here. You kind of get a glimpse of it here. And actually, there doesn't seem to be much appendage in this view. So it's looking very interesting. So if I did a couple of measurements here, so if we measure the orifice at the top here, something like that, and what does that come out as? 23. And then if we were coming a bit further down for where we think the orifice might be, maybe here. I'm not quite sure in this view because I haven't got good landmarks. It's not a view I'd always rely on for the measurements. As I said, I use 3D, but that's the first view. We've put colour through this already, so we know that there's no... 45. Yeah, that's good. That's lovely. So here you get a better view of it now. We'll just put a little bit of colour in there, just to make sure we're happy, which we are. And then let's just look at the appendage now in detail again. I'm just going to explain because this anatomy is looking very interesting. So you can see here we have, in fact, you get a glimpse of it as we move around on the right window. So this is the orthogonal view. You can see 2 very short lobes.
Bushra?
Yeah.
We see a very nice image, but we don't see the angles. I assume you're at...
We're at 45, 50.
45 and 135, yes?
That's right. 45 here, roughly, and 135 here.
Thank you.
Yep, sorry.
No, it's not. We have a
just
picture in the corner which
the
obscures...
picture, the top left picture needs to be moved to the bottom if they could. Oh, that's it.
Okay, so we're just showing you the top of the Warfarin ridge here, or the Coumadin ridge, and you can see here, this is the orifice, and the circumflex vessel is here. You can just see glimpses of it coming and going, so it's quite... There it is there, yeah?
Yeah.
So you can see actually there isn't much lobe beyond that point. So we'll keep going. We might just do a quick measurement while we're here. It's looking very, very... So if we took the whole of the top of that orifice there, we're getting 25, and then we get at the level of 16.
Notwithstanding it being relatively shallow,
yeah,
it looks otherwise amenable, doesn't it?
Good question. We're still looking.
Could you put some colour on, please?
Yep.
Oh, sure, thanks.
So, colour, wrong button. Yeah. So we can't see much in the way of colour. We can bring the scale down as well. Oh, good, you've done that. So we've taken the scale right down to around 30. So again, we're seeing nothing. And we'll just go back up. Lovely, which you did. And we're just going to keep going round now, if that's all right. We're going to go, we've done 0, 50, now we're doing 90.
It's almost closed, isn't it?
It is. It's a big, massive mouth.
We are
and
done,
it's
huh?
tiny.
Well,
Yeah.
my point was going to be that if ever you could stratify a particular appendage into a high risk or a low risk thrombotic category, not sure how you'd describe this.
I would. The tiny lobes that we're seeing, if that's the right word for them, trabeculations almost, it seems, are potentially nidus for thrombus formation in a low flow state, I would say, given how small they are. We're just going to do our last view at 135.
Jens Erik, happy to have a go at this?
Yes, I think it can be closed. It is very funnel shaped, but For instance, an amulet could be a solution for this appendage.
Peter, you've had your breakfast.
Well, I think it's suitable for both devices, probably. We should see
Which both?
Amulet and Watchman. I think it's for both. Because it's one lobe in the top and getting wider in 2 lobes in the bottom, and I think it's suitable for both.
Okay, Iqbal.
I haven't got any experience of the Lambra, but it does look as though that might fit very nicely because of the taper. I would not put an Oculotech device in this, not enough grab.
Okay. Kevin, where are you?
Here, Shaq. I think maybe something with a small, small umbrella and large cover, one of those special type devices, one of the 17 available devices, Neil.
It's not nearly enough.
Hideki, what do you think?
Yeah, from a standpoint of the beginner, I think it is a little bit difficult to implant the Watchman, so we need to pick up the orifice-oriented device, like an amulet.
Okay. Yeah, Matt. Yeah.
I think there was a brief glimpse of the 135 view, which showed anterior depth. So I think we might be underestimating the depth, and I think we could get a Watchman in there.
Watchman. Other Matt.
I like the suggestion for the Lambra device.
Yeah. Okay. Horst.
So, Busha, just give us, she's doing some additional measurements. So, Busha, when you have done that, please show us again the 135, because that seems to be the most critical in this particular patient. And the reason is that I saw, basically, as Busha described, a ridge which is going up to the orifice of the appendage, which means she has basically, this patient basically has 2 little appendages side by side. There's no actually functional landing zone, but the strategy during this workshop is that we have kind of pre-selected the patients for certain devices randomly, more or less. This patient is kind of pre-selected for the amulet, but we can change the strategy if we want. Yeah.
So I don't know if you can see the screen. I'm just looking at this anatomy in 3D.
Yeah,
so
they see the screen. Yeah, okay.
So you can, if we start at the 45-degree view here, so there's the Warfarin ridge, there's your circumflex vessel or your vein there. You can see the very wide orifice and then how it tapers very rapidly to a small size there. And if I just swing round, so this is the 360 look round. It gets, you can see now, you see in long axis, you can actually see that you've got at least 2 little pouches or lobes, if you want to call them that. They seem rather small for that. And if I just move through those, I can get an idea of what the anatomy looks like. And they're very similar. They're both very narrow, very small and very shallow. So really, as Horst was saying, I can't easily discern a landing zone here, given the shape of the way it goes from a very broad, wide orifice, very oval, where we're getting 35, 36 millimeters all the way down suddenly to about 16 millimeters.
So, Busha, in your own unit, what would you be advising in terms of which device to use?
So we really have the St. Jude one available to us on a regular basis. So we probably would not close this appendage, I have to say, looking at this anatomy.
Okay.
Yeah. So can you kind of measure the length of the functional landing zone, which means from the level of the circumflex to this ridge, which is dividing the appendage into 2?
Yeah.
Yeah, this is the important image here. Yeah. Okay.
So Horst, do you
is
mean
that 3
from
or
about
2
here,
ridges?
here to there?
Yeah.
Looks like 3 there.
23 millimeters we're getting.
Yeah.
Yes, there are 3. There are 3 small lobes there. Yeah, that's right. You can see them here. I'll just point them out.
Where's Maurice?
Anterior here, and then middle and posterior.
So the length of the functional landing zone, can you just point it with your arrow what that means? That means from this plane towards to the ridge, the distance. And
so that distance is 20.
That's the diameter of the landing zone, and now the length of the landing zone.
Okay.
Peter?
I think in this case,
do you mean the whole lobe, Horst? Here
yeah,
to
this would be if we are able to put the device into that particular lobe.
So now it's 23 millimeters.
Yeah, and but measuring to the ridge, which is the functional landing zone.
Okay.
So that is almost 0, isn't it?
Horst, Peter's got a suggestion for you.
Yes.
No, Horst is going to look for the same thing I wanted to
6
ask.
millimeters.
The distance between the orifice and the ridge is very important if you use an amulet device, because you have to have at least 10 or 12 millimeter length to bring in the body of the device.
Yeah.
The
So
lobe.
here it is, Peter, here is the 6 millimeters, which would be too short for the amulet,
Probably
right?
yes.
Yeah.
So, Peter, what would you suggest then?
Well, we could try a watchman device, because if you can get into one of these lobes, probably in the middle one, it might fit that it opens up at the orifice to its original diameter. It depends how long or the diameter. It's 23, I think, so 27 would be suitable.
Now, Peter, look at this.
Okay.
This is the landing zone into the middle lobe,
It's
and that is
16.
16.
Okay.
For
Matt,
twen-
Matt,
for-
I think it's probably feasible with the Watchman. The lack of clarity is how rigid the septae are between those lobes.
Yeah.
So you could get a device with adequate depth in the anterior lobe, but the feet may never expand.
Iqbal?
So with this fantastic imaging, isn't it one of those really shallow ones that either you do as Bushra suggests and don't do it, or use what was shown by Kevin yesterday, that sort of funny Lambra device with a small waist?
Kevin, is that what you would go for?
Oh, no.
Yeah, let's see what the angiogram looks like.
Okay, let's do the transeptal puncture now. I would like to have long axis view and short axis view of the septum. Kind of explain. Schon mal nach Lambda devices gucken. So I'm high up in the superior vena cava. So please also show my hands. Yeah. So the arrow of the needle is pointing towards 5 o'clock. So I'm coming down with my catheter. This is the St. Jude transeptal sheath.
You converted, Horst.
No.
Yes, you did.
Well, I thought it's fair enough when we plan to use the St. Jude device, then also to use the St. Jude sheath. Okay, so now it looks like I have lost contact, huh? So, yeah, okay. So what to do when you have lost contact with your needle to the septum?
Well, the correct way, of course, is to go back with your wire to SVC.
Mm-hmm. And then?
Well, try again, of course.
Okay. So what I would like to do is I will change the configuration of the needle.
Yeah.
Because I had good contact with the septum secundum when I was high up. I lost it just because the curve of the needle may not be enough. So let's change that. Okay. You see on echo, you see the needle or the sheath in the SVC.
Horst, have
as
you
it
ever
comes down, yeah.
have you ever broken the tip off a needle?
Broken the tip of the needle?
Yeah.
No, I don't think so.
Well, I'll tell you.
Have you?
Not so long ago. I mean, it was not a left atrial appendage, but I had a small child with a very tough septum, and like you, I bent the tip of the needle. Still couldn't get across. Tried several times, and I felt like a sort of break. The needle didn't embolize, but when I took it out of the dilator because I was no longer happy to proceed, just the act of taking the needle out of the back of the Lua lock, the tip of the needle broke off.
Wow. So I had better contact initially, but now I lost contact again. So that means I have to do this again. I will give a little bit more bend to the needle. Because I want really to see, if possible, the tenting when it comes to the septum.
Yeah. So we discuss it. Do you have any other technology available? We have the Baylis stand here with its NRG needle, and of course the radio frequency wire. Do you have that available or not?
No, we don't have that, no. We have used it in the past, but just for live cases, or so we don't use it. I mean, the problem is rarely that we cannot get through the septum. It's in this case here, it's more I need to have the contact because I want to see where I puncture. So I made more bending here. Well, if you have the situation that we cannot cross, which happens in 1 out of 1,000 or so, then you can use, for example, laser. We have the laser in our lab. And I remember a case of a parvalvular leak where we had to use that long time ago, actually. So now you see again the tenting at the fossa ovalis. So I'm coming down. Lost again? Wow. Huh? There's
a bit of.
There's still a little tenting. Huh? You see it on the short axis. It's in the posterior area of the septum.
That looks.
And we are in the inferior area. So is that a good position to puncture? What do you think?
Peter, are you happy?
Well, I think as long as we don't know which device we use, we can choose a special point for transeptal puncture. Okay. But it should be inferior and posterior, I think.
So are you satisfied with the puncture location, Peter?
Yeah.
Yes, he is.
Don't say later on, Peter, that's not a good position, as you usually do. Yeah, he seems.
Matt, are you happy?
Right now, I don't see it.
Looks fine to me.
Okay, so I will puncture
the Californian mat, as opposed to the Oxford mat, or both.
We'll move.
The Californian wants to move to Oxford, by the sound of it.
So we still have that tenting here. Is the position still okay?
Looks perfect position.
Okay. So then I go through. I advance the whole system a little bit. So it does not go through. What to do now?
Push harder.
Push harder. Now I'm through.
Yeah.
I just kept on pushing a little bit. And now I'm through. Little contrast. You also see the pressure on the screen. Yeah, you see it there. Pressure, mean pressure is, well, about 9 or 10, so it's going up and down. Now I rotate a little bit to 3 o'clock before I advance the whole system. And now I'm advancing the whole thing. Little resistance, that was the transition from the needle to the dilator. Now I keep the needle in place and advance the... Now it's popped through.
There you go.
Okay. Now I keep the dilator in place and advance the sheath only. Good. So now...
Left atrial pressure's fallen by the look of it.
Yep.
Let's check 0 again. I'm not sure about this pressure. So...
Then at what stage do you think about giving fluids?
Yeah, that's what we do if the pressure is too low. We are just rechecking 0. Okay. Let's de-air the sheath, very important, of course. Keeping the hub down, turning the sheath around to make sure that there's no air in the
My
valve.
perception is that
Now we will give heparin 10,000.
May be different for you, Horst, but my perception is that we're a little more assiduous, let's say, about checking the left atrial pressure and giving fluid if the left atrial pressure is low. Roland Rossi, you thought I'd forgotten about you. Roland, in your institution,
yes,
are you concerned about left atrial pressure and fluid, or not particularly if everything else looks good?
We try to get it between 10 and 20 millimeters.
Thank you.
Matt, you used to be an advocate of appendage volumes and left atrial pressure and so on. What would you do? This is around mean of 4, I think.
I would give a leader bolus and just continue as I go. So yeah, so I do check and I'm aware of the pressure and try to get it above 10.
Mm-hmm.
So pressure is now changing between 8 and 10.
You've got SD changes as well.
Oh yeah, why is that? As you have seen, I de-aired the sheath. Let's do this again.
Yeah.
Mm-hmm.
Maurice, Happy with this left atrial pressure? You want some more?
Yeah, more.
How much?
Usually we give 500 to begin with, obviously as long as it's not patient with a reduced LVEF.
Busha, do you see anything special? We have ST elevation changes.
Yeah, we're looking.
Despite carefully de-airing the sheath, so something is wrong here.
Yeah.
Any thrombus, any clots?
Just look at the LV.
Just given heparin 10,000.
It's just worth thinking about, isn't it? Because these are comorbid patients, obviously not particularly this one, but
I'll put it in 3D. Nothing obvious.
every now and again I should think you've got to be careful about a rapid 500 or 1,000 cc transfusion.
Can we check ACT?
So it must have been a bit of air, mustn't it?
Yeah, but we didn't see this, neither on echo. I de-aired the sheath, so I don't know what I did wrong here, but there's clear ST elevation.
LV, full chamber.
Could you check LV contraction?
Yeah. We're just doing it now, actually.
What's about the LV?
We're doing it now.
Here we are.
That's okay.
And blood pressure horse, that's okay?
We don't have invasive blood pressure measurements, but we can check with the cuff here.
It's beginning to look less aggressive, I think.
Pulse is
they're coming
good.
down, aren't they?
It's good. We will check ACT to make sure that she has enough
there's no
heparin.
wall motion abnormality or anything else. I mean, it's probably
Yeah.
transient phenomenon. It's going to get better.
It's settling, yes.
Maurice just wants you to carry on now.
Yeah, okay.
Carry on. It's getting better.
Yeah. So here's ACT.
Do you also have an arterial access, horse?
No.
We never do this routinely.
Peter, do you?
Usually I do, and I put in a right coronary artery catheter just for having pressure control. And if there is a problem like that, it's a quick way to go for the right coronary artery where air usually goes in if there is an air embolism.
And what do you do if you see air in the right coronary artery?
I just inject contrast dye and I blow it out.
Okay.
Let's just... Roland, do you have arterial access also? Invasive arterial access?
I don't understand your question.
When you're performing left atrial appendage closure,
yes.
Do you have arterial access also?
No.
Okay.
See, I think that the difference here is that it's not under general anesthesia, right? So if you do the TE under or TOE under general anesthesia, you have to have that A line by definition.
What do you mean by definition?
I mean the anesthesia, whatever their society has that as a requirement.
Oh, really? That's
Yes.
interesting. Daniels,
Iqbal?
what do you do in Oxford? Do you have arterial access or not?
Oh, hold on.
For these elderly patients who we're going to give a GA to, we do tend
You
to.
do, okay.
But there's no requirement to.
Yeah, so in the UK there isn't a requirement. So all the PFOs and ASDs, they get GAs. The TAVIs sometimes get GA.
Yeah, we don't do
it's
arterial
not a
access.
routine.
Yeah, it's the American way.
So it's American definition rather than...
Is it billable?
Of course.
No, they don't care about billing.
No.
It is billable, definitely.
Okay, Horst, you've done some angios there.
So blood pressure is 160.
Okay.
I have done the first angiogram with the pigtail in the inferior lobe. Let's show this again for those who haven't seen this. So here it looks in the very small inferior part of the appendage. And now I repositioned the pigtail into another lobe. Yeah, and what you can see nicely is actually what Bushra has shown us on TEE. There are 3 lobes.
And a little mini appendage.
Yeah.
Well, what's clear is you must exclude that very, very small superior.
Yeah, of course. This is probably the most important one, isn't it?
Yes. Maurice, what do you think of from the angiogram? You missed the echoes. I was looking for you earlier on, but on this.
Yeah, I kind of by angio alone is a 2D, so I'd like to see the echo before making any comment.
You weren't here when we were.
Sorry. Here, yeah.
You might see it now.
Ballpark idea. So we've got 45 degree on the left and on the right you've got your 135 view. So you can see the orifice is quite broad. It narrows rapidly to a short lobe, and then in the orthogonal view you can see the circumflex vessel coming in here. So this would be our landing zone, and then you can see here we've got 3 very short lobes, and this is the PA, so anterior lobe is here.
Yeah, so that would qualify as one of the more broccoli type, where it's kind of broad-mouthed and shallow in depth. The probably challenging one, yeah.
And what would you do?
I'd probably go with I found the longest, largest lobe, and try to be more proximal than I would. And this, I don't know the number. What numbers did you get in terms of diameter?
So landing zone was 23 millimeters.
23.
The widest, and then also, so this was in the 135 view, the view on your right, and the longest lobe that we could see when we focused on it was the anterior lobe, which is about 24 millimeters.
Yeah, so I would go with the anterior lobe, and I would be a little bit, I think the trick that we have learned is to be a bit diagonal in the sense with the sheath, with whatever device you're going to put. So I think there's enough depth for the width.
Using what size and type of device? Watchman?
So if I'm doing Watchman, you would have, if you have 23, so you're going to be maybe somewhere between 27 and 30, and you have to be able to find a place where you could put a 30.
Okay.
So, Maurice, when you look at the image here of the fluoro, you can see that the landing zone has 26.
Yes.
And the length of the longest lobe is 24. But this is not the functional landing zone, which is it's only 6 millimeters, the functional landing zone. So
you will have a shoulder if you're doing the Watchman, but it is a kind of understood shoulder that you have to know from the beginning.
Well, the concern is here when you put, I mean, it's a difficult appendage.
Yes.
If you think about the Watchman, it may be that the distal end of the Watchman gets stuck right here in the distal end. Then the proximal part cannot fully expand, and then you have uncovered inferior lobes like here and here. I don't know whether you can see my arrow on your screen.
I don't see why this isn't a perfectly reasonable case for the amulet.
Yes,
Jens Erik, come on.
Yeah, I think you could put in an amulet. I mean,
Jens Erik is desperate to put in an amulet there.
Which size?
I would probably have a little bit more measuring of the landing zone. I think we saw from echo diameters down to 16, and now we see on angio 25. So also a measure of the orifice by echo again.
Yeah. Well, Bushra has done all that.
But what is the largest diameter of the orifice?
We're getting 23-24 millimeters at the biggest for the in the 135 view, and we're just going to quickly see if we can do this on our 3D.
Kevin, it's still okay, isn't it?
Yeah, I think it would be fine for either device. I think with the amulet it may be a little more difficult, but I think you could certainly do it with the amulet.
Which size,
I
Kevin?
I think it's doable with either, but I think also.
I think the lamprey would be if you measure the anterior lobe to choose the actual umbrella and your cover. I think that would be how I'd select device there.
So we've got choice of 3 devices now.
So let's start with the amulet, and we can change later if we want. So Kevin, if you try this with an amulet, which size?
Maybe an areocranial view.
This is areocranial.
Okay.
This is caudal.
Try a different one then.
No, an areocranial for amulet is often better.
That's what this is.
No, it's caudal.
He just said cranial.
Yeah, this is caudal. Yeah.
Oh, caudal.
Yeah. So I do another cranial.
Yeah, you see, the angio is a little bit more, in this particular case, the angio is a little bit more hopeful than the echo for either devices, and I could speak for the Watchman best.
Yeah, I mean, the areocranial is always looking nice, but here again, in the caudal view, you see what the problem is, right? The short landing zone. Okay, so we are still not, I still need more recommendations regarding the size of the device.
We've got some more measurements if anyone's interested.
Okay, Bushra?
Jens, go on.
So can you see
What was the measurement in the RAO cranial view from angio?
Okay, let's do that.
Neil, what you seem to be more convinced that one device is better than the other.
No, not at all. But I'm certainly happy that there's room there for an amulet. I think the Watchman might be a little more difficult, but
okay, so here.
Because of the depth, more like.
Yeah, so these are the ones, the so-called broccoli types, that we do. The sheath should not be necessarily hugging the Coumadin ridge. If you leave the sheath a little bit diagonal, you gain some more space, and the device cants by itself. So this is one where the classical sheath positioning does not have to follow.
Okay, Kevin, with those measurements, what do you think?
Which measurement do you like?
The one between the 22 and 16.
Okay.
So I think 25 amulet would be a good start. You might have to go down, you might have to go up.
Mm-hmm. Jens?
25 or 28. I would like, again, the measurement of the orifice, because if we take a 25, we have a 32 disc, and I would be sure that we reach all the way up to the pulmonary vein ridge with the disc of the device. It looks a little bit large, the orifice. I think the line 27 here is not completely correct.
See again?
I've got some 3D measurements.
I think it's larger.
But
12, yeah.
Okay, what have you decided then, Horst?
We go for a 12 French sheath and start with a 25 amulet. I have, there's always a debate about how to exchange the sheath. I'm using the Ampert's extra stiff wire and making a loop like with a pigtail, as you see here. So it's important to, if you do this over the wire, then it's important to use Ampert's extra stiff with a 3 centimeter tip, because only that behaves like a pigtail. The other technique many other operators prefer is to go to the pulmonary vein and exchange in that position and then go down with the sheath into the appendage. I think both techniques are good alternatives.
Did you also shape that wire a little bit, Horst?
No, it makes this curve. If you take the Ampert's extra stiff with 3 centimeter soft tip and angle tip, of course, then it always makes this shape like a pigtail. Now I'm retrieving the sheath, keeping the Ampert's extra stiff in place, or we need to prepare this here. So this is the 12 French sheath that comes with the amulet device. Let's focus on the tip.
So 2 curves.
2 curves. This is the curve in one direction.
So
and when I rotate...
45, 45.
Yes, and here double curve. And here you can see the anterior orientation of the distal tip. So that's why it's called double curve. And we talked yesterday about our sheath and importance of size. So this is a 12 French, which is reasonable. 14 is actually sometimes difficult to bring it into the groin. And you have to be careful not to cause a kink in the wire. So the 8 French transeptal sheath goes out.
Kevin, would you use a double curve or any?
Yeah, I think the 45 by 45, I think, is used for all of them now.
But Kevin, you have used the ASD sheath in the past.
Yes.
Yeah, exactly. But I think with the amulet, it seemed to change, and it wasn't easier to get alignment of the lobe with the axis of the appendage.
So when you go through the groin, as I said, sometimes it's difficult. So important is to rotate only in one direction. Have a short distance when you grab the sheath. Well, cannot see this here, but short distance,
so
rotate in only one direction.
Horst, why not put a primary sheath like 14 French or something like that to
that's by far too expensive. It's different in your place, but yeah, but it's a good. You mentioned that yesterday. It's a good idea.
Oh
You could pre-dilate with a short dilator.
Yeah, that's also an option, yeah. So whenever you have problems with inducing the sheath, then you should use one of these other tricks, because when you have a kink in the wire, then it can really get complicated. And I have seen cases where the sheath was advanced in the subcutaneous tissue. Let's zoom out here so we can better see. Now again, this is a situation where you have to pay attention. So it's close to the septum, and I have to orient the curve of the sheath so that it directs towards the appendage. I'm slowly rotating.
The thing about the 45-45 is just occasionally you can flick the wire out at this stage coming across the septum.
So I'm carefully advancing now. Yeah, zoom in, please. Now at this point, I keep the dilator in place and advance the sheath only. Okay, please note that the marker is not at the distal end of the sheath. There's a distance of about, I think, 4 millimeters.
And Horst, I noticed you took the wire out.
Yes.
I prefer to just keep that in until I get the blood back, but
yeah, same.
You obviously do it slightly differently. Maurice agrees with me.
Mm-hmm. Yeah, sometimes inadvertently, whoever's moving one part or the other advances it, so you always have especially if you work with fellows and whatnot. So you have to be careful about that. I think it's an important part.
So there is this little adapter here, because the lure lock is different for the sheath and the regular lure lock.
Have you been giving extra fluid as well whilst...
Yeah, fluid is running. Yeah. And we can recheck the LAA pressure. Look at this, huh?
Mm.
That is the area where Maurice wants to place the distal end of the watchman, right? Mm-hmm. Okay, so let's prepare the 25.
Not exactly. But before you go, I mean, you're looking at it angiographically. How about if we look at it on echo?
Yeah.
And see where maybe you are not in the position where you think you should be ideally.
Big syringe.
Bushra?
So we're in that standard sort of working view, 45-degree on the left and 135 roughly on the right. You can see where the sheath is. You can see that it's coming into the appendage. You can see the proximal portion. And we're just looking at it from on the other side. If I can just bring the cursor up. It's going...
If ever you wanted...
Where is it on the 135?
So you can see it just there. Yeah. And it's heading into... We lose it, actually. There's a shadowing. We can't quite see where it's placed. Yeah. And we can see the middle lobe and the posterior lobe nicely. Yeah. So it must be in the anterior lobe.
I mean, looking at the left panel, if ever you wanted a coaxial sheath, that's perfect. I think we'd all agree that looks good.
But like we said earlier, if it's amulet, maybe it doesn't matter, but I'm saying it just in terms of these appendages, you don't always need it coaxial. Sometimes you gain more depth by non-coaxiality.
Agreed, and of course we've to advance the device, which may change the orientation of the sheath anyway.
And angiographically it looks inferior. But the advantage of the amulet is that you can form the ball and then counterclockwise it up to the anterior, which probably has a bit more space.
Yeah, my guess is that it is in the inferior, or heading towards the inferior. That's what we saw angiographically.
Oh no, the sheath now is definitely in the superior. When you look at the look.
Yeah, we can't even sort out whether it's anterior, superior, or inferior at the moment.
Look at this very small 2 millimeter appendage Neil mentioned initially, which is so important to close, which is 2 millimeters, just proximal of the distal end of the sheath. And please keep this in mind, and I will go back to the areocoral angiography we did initially, which was this one here. So
in the 3D image, can I just show the 3D
Yeah, you can
image?
just see a little bit of contrast
Yeah.
going in.
Yeah.
If you're looking at...
It's the usual, the angiography, and I know, of course, you must use the pigtail, but the angiography, for me, is always better through the sheath than the pigtail, because the side holes of the pigtail, of course, are well proximal to the actual.
So I'm just de-airing the amulet comes preloaded in contrast to the ACP. So I'm just.
Why must you use the pigtail for the angiography?
No, I'm not saying you should use it for the angiography. I mean, you must use a pigtail to engage the left atrial appendage.
For maneuvering inside, but not.
Yeah. Rather than just going straight with the sheath.
With these images, haven't we found that there is now a small landing zone to tether something in? It's looking a better bet now than it was before. So I think the angio and echo do match now. I think we are in the superior lobe, and now we've got a landing zone, hopefully, in that lobe.
So I have de-aired the introducer delivery system. And can you flush from here? Okay. Just once. Good, stop. So I'm advancing the amulet device. This is the distal end. And now I will deploy the device.
Horst, I take it you gave your usual 10,000 of heparin?
Yes. We checked ACT at 350 is ACT. We checked this after having these ST elevation. 350.
Which is going totally...
Yeah. ST segment is normal now.
So, Horst, with this very small appendage, are you actually pulling the sheath backwards a bit, or are you pushing forward with the device?
Well, I'm pretty far distal, so what I'm doing is I keep the device in place and pull back the sheath, because this small lobe is certainly too small for the device in any case. I would like to see this little ball, and now ask Busha where this ball is. Yeah.
There on the right image.
Please, could we? Could we see echo in big frame? Thank you.
Rolling their probe there, so you can just see back slightly. That's it. Stop there. You can just see the ball is sitting here. We did have a slightly better picture, but it's there, and it's definitely in the superior lobe.
Which would be too small to expose it there, so I have to pull it back here. The whole system, yes. Oh, it should be more proximal.
That's better, yep. You can see it there. It's come back up slightly.
My guess is that this will be not possible with this device, but let me continue to try. So I'm opening it a little bit more.
If we have fluoro image as well, please. And echo, yeah.
Where I'm now?
So you're just sitting just near the landing zone there. The lobe is coming out more now.
And here you can see how short this landing zone is. So I slowly pulled it back, so I'm at the orifice of the superior lobe, it would like to say that. but I'm almost out of the appendage. So that means there's almost no space to place this device, right? Let me try pushing a little bit more. So I'm keeping the
Jens,
sheath.
what do you think, position-wise?
I think if you look at the transversal view on echo, it looks quite okay. I will try to expose the lobe and re-evaluate again if it's too proximal or if it's okay.
I think in the short axis on the left side of the screen, I agree it looks good. When I look at the right side of the screen, which is the 135 degree, there's some overshadowing by the sheath, but there seems to be a big gap at the inferior edge, right? And this will be the problem here.
But it's, with the device only half out, it's,
Yeah, so I'm slowly exposing it.
And you can see the relation to the circumflex is okay. You are distal to the circumflex.
Just remind us, Horst, is this 25 device or which?
25, yeah. You see what happened?
Yeah.
Can we see fluoride?
Make it bigger.
It's completely tilted, huh?
Yes.
And now it's out. You see that the even in the short axis, it doesn't look good anymore. But let me expose it a little bit more.
So, Maurice?
Kevin?
Anybody think we can salvage this by a different sheath orientation, Dr. Daniels? Or are you resigned that this is not an appropriate appendage or not appropriate device for this appendage?
I voted for Lifetech at the start, and I'll keep voting for Lifetech.
Kevin, and then Iqbal?
Yeah, I mean, it's obviously usually worth another deployment to see can you get a different angle. But I think the septum between the lobes is making the landing zone very short. And I think you'd end up having to maybe go down to an 18 to get distal into that lobe, and then your disc is going to be maybe too small to cover the inferior part.
Iqbal?
I was going to make the same point, or as an 18 device or switch to a Lifetech.
Okay. So an 18 device would be too small to cover the orifice, right? Do you agree?
Yeah.
Here you see again on the 135 that the lobe is actually outside, at the inferior edge it's outside of the appendage, and that is just because of the ridge between these other lobes. Okay, so
Horst, just talking about the 18 device, that would add, what, 7.5 or something to the disc. So it might sit slightly inside the ostium of the LAA, but it might still be above that little micro pocket. Worth a try?
Yeah, okay. Let's go for the 18 amulet. I'm just flushing the sheath.
So what will you do with the distal part of the sheath? Reposition it, or how would you do that?
Let me check with Andrew. I think I'm still okay.
I might have been tempted, as you just had one go with that 25, I might have been tempted just to try a slightly different sheath angle and deployment, but
Well,
Eric is
yeah,
nodding, so
okay.
he agrees with me.
I didn't know what to do differently because I was in the anterior lobe. I pulled back until it jumped above this.
But the orientation of the device,
yeah,
in the short axis at least, didn't look quite right, and I just wondered if you might have been able to influence that.
J1, any thoughts? I think you came in a bit late. But
I totally agree with the proceedings now, because 25 is too big, and you have to go to the superior lobe, because behind the neck, just at the moment of separation of these two lobes, there's a strong angulation, anterior angulation of the appendage, which resulted in flop out over the circumflex artery. I think this is a good option to try 18.
Okay.
And hoping that the disc is big enough. Otherwise, I think Lifetech would be a good option.
Just de-airing again.
So, Jaiwan, which of the 17 sizes of the Lifetech device would you choose?
Yeah, the special sizes, small, small umbrella and big disc.
The 1832 or 2032, the 18 and 20s have the same 32 disc on them.
Mm-hmm. Certainly got bigger choice.
Okay, so let me start more distally. I'm rotating counterclockwise. I think I'm now at the orifice of the superior lobe. I'm keeping, the sheath wants to come back, so I'm keeping this. And can you advance the, please? Stop slowly. Mm-hmm. Okay. Mm-hmm.
Don't want to disturb you, but there was a phase with the amulet that when you advanced, you got fairly distal in the sheath, and then you reassured yourself that you were still connected by withdrawing the cable somewhat, but maybe that problem's been solved now.
Okay.
Echo looks.
What do you think?
Better.
Looking
certainly.
better.
No. No, there's something not good in the echo.
So on the
well, the short axis.
On the 45, it looks not bad, but on the 135, you can see that actually, first of all, it's not covering the posterior or inferior lobe as Horst had already predicted, and then also that we are above, a little halfway above the landing zone.
Yes, it's much.
So we are actually touching the ridge between the different lobes with the lobe of the device, and we still have a gap. So there is no compression, and I cannot advance the system deeper into the appendage. What I could do is to try to put the device in the superior lobe, but I'm assuming for the superior lobe it will be too big.
Let's see the disc, Horst. Let's see the disc.
Well, but the device is not compressed. Look at this. It's fully open, right? And you see this on echo as well, so there's no compression at all. So I would not be able to
leave it there, yeah.
Leave it there, right?
Okay, Jens, what now?
I think the orientation now of the lobe is okay, but obviously it's too small. But if you had the same orientation with the 25 device, because now you are in front of where the appendage divides into the three lobes. And that's where I think you could maybe again try to put a 25 amulet.
We still have this here.
What about trying to recapture it and pushing the ball slightly deeper in that appendage? Do you think it's too small to do that, Horst?
Well, I see here on echo that I'm touching the ridge, right? I'm touching the ridge between the two lobes, or three lobes.
J1?
So
I agree with Iqbal. Try once more getting more deeper into the superior lobe and a slightly more counterclockwise rotate, that you have an engagement of the right-sided hooklets in the wall of the superior lobe.
So I did this here. Okay. This is very strong anterior.
I think you should straighten the device in the sheath by violating the IFU and pulling into the sheath and moving a little bit so that you have a straight angle.
J1, I like that. Violate the IFU.
Up.
Yeah.
Oh, it's far out, huh? Okay, so let's try once more, then we retry the 25.
This is very
you
interesting.
just tried the 25.
Well, in a different orientation, deeper.
The point was we should use the same orientation as we have now. It's not much different, actually. Let's.
Yeah.
Now it's far in.
Echo's not being very helpful.
It's actually selectively in the superior lobe.
A bit
It's
of
certainly
compression
compressed
there.
now, isn't it?
That looks interesting, huh?
It looks very interesting on echo.
What did you say, Bushra?
It looks even more interesting on echo.
I can't hear Bushra.
Interesting as well on echo.
Oh, all right.
Well, we see the disc is probably too small, but can you go to 9.9 again? Yeah.
Little angiogram now, I think.
Yeah, it's too small, huh? You see the gap at the inferior edge.
Yeah.
That's small.
So
Superior
now,
Wilson lobe is
Jens,
still patent.
What would you do now?
But this is still the 18 device?
Yeah.
So I would go again with the 25. I would expose the lobe to the ball configuration before I was in the superior lobe, just in front of where there are this lobe division, and try to have the perpendicular orientation of the lobe.
So everybody agrees that the 18 is not an option?
I would tuck very gently.
I mean, here can actually tuck pretty strong.
I suspect we're happy that it's secure.
And do another angel.
What's the point, J1? You think it's repositioned?
To get more relaxed so that the gap, I think the gap is not that big.
Oh. Maurice?
The question is what happens when we release the device? So it could be
there's the half of it that's uncovered. You can see it on angel.
Yeah.
So I think that's too small. I just worry that if you try the 25 horse, that there will be no landing zone for that. The way that lobe has gone in is what we probably do want, and maybe it's just that the 18 is too small. We go only one size up, and that might cover it.
Well, it sounds like from this experiment, what was mentioned earlier with the Lifetech, the special device with the bigger disc, is exactly what
you need.
What this seems to be, because it's a small ball and the big umbrella.
Yeah.
It would be worth measuring the lobe there just to see what, because that's the true stretch diameter.
And it's expanding actually.
Yeah, this is you can measure measurements right there, and then probably that's the device that was
It's
working.
wider now than when it first went in.
Bushra, can you measure the gap, the leak? I think this is less than 5 millimeter.
Yeah, but it's not a matter of the leak. It's the pocket behind the leak. It's part of the appendage, right?
Just looking at it now. Just push the probe.
So Bushra shows the echo whilst horse is doing measurements.
Yeah, we're just getting there. Just push the probe a little bit more. And now gently roll. Other way.
So you see on angiography the lobe diameter with the device in place of the superior lobe is 13. Now the orifice or kind of landing zone is 23. And the distance between the landing zone and the ridge between the lobes is exactly as Bushra measured on echo, 6 millimeters.
So maybe a 1630 lamprey.
Yeah.
Which one? Sorry.
1630.
Mm-hmm.
Okay.
So not those, the 1532 then, which is the one you suggested before.
1832 might be okay, but we only got 13 millimeter, when that compressed.
So you want the 1532, the 1432, or the 1832?
No, I think they're all even numbers.
But we're not sure.
Okay,
so,
what do you think then?
I'm waiting for Bushra for the residual leak, how big that is.
We're just trying to get some images at the moment.
Yeah. The question is what happens with the disc when I release that device. Will it then move towards the leak or in the opposite direction? I don't know that. So the leak may either disappear or get bigger.
Do the 45 and we'll look for on Explain.
Haben wir das gespeichert? Ja. Mhm. Beenden.
Maybe you could start with the shallower views if the 135 is difficult.
Well, but 135 is here the important view, isn't it?
Yes, but I mean, start with it.
Yeah. Okay.
Because if the shallower views still show significant,
look at this. It's getting better over time.
So there you can see the gap there.
Sorry, Bushra, I can't hear you. What were you saying?
See the gap.
The gap is there with the lobe. The inferior lobe isn't covered. I'm just going to scroll back and see if I can show it to you. So you can see the gap here.
Yeah.
We're not quite angled enough because we're struggling in the 1-5 view to show an image, because you can actually see there's a gap here which looks a few millimeters, and you can see flow around the edge of the device, but we can't quite see it in this view here. But I hope that kind of there you can just about see it coming and going here.
And shows the flow as well.
Right there, yeah.
Mm.
But now it looks like the disc is almost touching the tissue, isn't it?
There it is, yes. There was a tiny gap. You can just see it coming and going.
But that's actually very small.
Yeah.
So,
is there much tension on the device?
So from this projection, I'm okay. I would be okay, but I agree with Horst that you don't know. If you release the device, then there may be a early remodeling, and it may become better or more worse. Mm-hmm. So I agree totally.
That's very helpful, isn't it, Jay? It's either going to get better or worse.
Yes, not to take a chance.
Or it could stay the same.
Yeah.
Bushra.
Yeah.
When you were talking yesterday about looking for a residual leak, you mentioned that you have to reduce the Nyquist limit.
Yeah, we've done that actually. You don't have to do it, but it just helps you look for any small leaks. We're just trying to get you a 3D of this image here.
Horst, what you can try is, as long as you have the cable, to push a little bit.
Well,
if it jumps in, then the probability, the risk of early remodeling in bad direction is high.
On 3D, you can see it nicely there, the gap. Can you see that?
Yeah, but if you keep that view and ask Horst to push, then see what happens.
So I'm pushing a little bit.
Still isn't making much difference, I'm afraid. Can you see that? Can you see what I'm talking about here? So this looks like it's 2 or 3 millimeters in width with a tiny flow, and then you see all this. You see that actually in its long axis, it's a lot more that's uncovered.
So, Horst, I don't understand why is it if you had a device that has a bigger umbrella and that basically you showed that you can be in the slope and you have up to maybe 16 to 14. Why are you sweating it?
Well, I mean, if Buscher tells me the result is good, then I certainly would prefer to leave this device here. But I think it's not good.
No.
Do you agree?
So we've got an inferior lobe that's uncovered, and then along and above it, we've got a disc that isn't covering the whole of that landing zone.
Okay.
And it's unpredictable what happens when you're going to.
Yeah.
But Horst has pushed, as I saw correctly.
Yeah. Well, I did both. I
did not fall in. So
no, it
for
doesn't
me it
fall
would be
in.
okay.
It doesn't fall in, but also it does not cover the leak when I push. So I mean, this is the maximum what the device could take on its own. This would be the best position the device could take.
So even though the remaining leak will be significantly less than 5 millimeters, so this is a condition where you in Watchman implantation you very often you have.
Well, that's not exactly true.
I
this is double hypothesis, not once. I mean, you don't know what's going to. You can't make that statement. I don't think.
Matt.
And I was going to say that
the point that it is 5 millimeter, 3 millimeter, or 6 millimeter is not the issue to me. Is the fact that there is an uncovered lobe.
Okay, Matt.
I think there is a difference between a residual leak with a Watchman and leaving the lobe partially uncovered. There's a difference. So here, this would not be acceptable for a Watchman result. I would.
Okay. All right, Horst, what are you going to do then?
I will exchange for a Lifetech.
Yeah.
Does anybody know whether we can use the amulet sheath for the Lifetech device? I think we can, right?
Kevin, do you know?
I haven't tried it, but I see no reason why not to.
Yeah.
Yeah. Okay. Why would you give up a good sheath position?
Yeah.
Yeah. So then let's. What do we have? Which special sizes? No. There's no cable, so we have to open that one.
J1 and Kevin, what size lamprey would you like?
The special size with the smallest umbrella. I think this is 18 or 16.
1630.
1630 or 1632?
No, 1630, and then the next is 1832.
16. So there isn't a 1632 then?
No, maybe there should be.
That would be 18 then.
Well, the smallest one is in 16 by 30 and then 18 by 32.
There you are. Yeah. So which one?
Take the biggest.
16.
Yeah,
Kevin?
16. Yeah.
Okay, we seem to have agreement.
Simon,
so we will prepare the device. Would you go for one lecture until we have prepared the other device?
That would be helpful.
Yeah. Okay. Good.
So we'll start. Thank you, Matt, for your patience. That was a good case to start with, Horst and Marcus. Nice to see you there.
Welcome back. So with me is Jatin Lam now. He has the largest experience in the lumbar device. We have used the 18 by 32. So that means the diameter of the distal part is 18. This one is 32. This device has to be carefully flushed with a pressure infusion line, and you have to use this pressure infusion during the procedure. So I'm just pulling it now back into the...
Horst, did you say this was 18?
It's 18 and 32.
Okay. What made you change up to from 16?
That was Jatin Lam.
Oh, and why?
Why?
In this case, because you measure the ostium is around 25 for 18 device. When you implanted the disc will be around 32 because it is like a satellite disc structure, so it will curve inward. So it will lose maybe 3 to 4 millimeter. So after implantation, the disc, if you measure the longest diameter, will be less than 32. So based on the osteo measurements, I think because if you choose 18, the cover will be 2 millimeter larger, then the chance of better seal the ostium will be higher.
This is first in man because, as I understood, nobody has ever used the Lifetech device with an amulet sheath.
Yeah. It's a fusion procedure.
Yeah. So I counterclock rotated the sheath again. So I'm looking on the fluoro. I think I'm in the superior lobe again. Busha, can you confirm that?
You're in the superior lobe. You can see that really nicely here. The sheath is there.
We will have to pull back the sheath a little bit before we expose the device and then push it in. This is important for the lumbar device and different to all the other devices. But I would like to keep it in position until I'm up there with the device. We have continuously flushing now.
Can I ask, is that a special thing about this device? Do you continuously flush every device? Because I don't.
Well, we flush only the lumbar device because, well, why is that? Because, well, it's because we are using a 9 or 10 French sheath, and then the space between the device and the sheath is very small. That means it's more risky that you actually get air into the sheath. I think this is the reason. We don't do this with the other devices. There it is. Yeah. So at this time, I'm now at the tip of the sheath. I have to pull back. I cannot just expose it there.
Can you do a cine? It seems that because sometimes after recapture of amulet, there may be invagination of the tip of the sheath.
Yeah, it looks a little bit like a fluoro.
So
can you exchange
that might affect the device when you're pushing out. Then it may not be able to do so.
Yeah.
Sorry, why you were making a comment about if you recapture a device, the sheath inverts.
The umbrella is very soft. For Lamprey device is very soft because you are using the amulet sheath this time. And last time you recapture an amulet device into the sheath, you might invaginate the tip of the sheath. And then if you push out Lamprey here, you might have difficulties.
Mm-hmm. I think it looks okay. Huh?
It's okay?
You think? Yeah. Let's cine this.
Yeah. Yeah, that's good. You can go deeper.
Mm-hmm.
Yeah.
Can you go deeper? Huh?
Yeah. Yeah, here, deploy here. That'd be nice. Is it very difficult to push it out? Oh, it looks nice.
Mm-hmm.
I think the umbrella is not fully opened yet.
Although the struts are pointing backwards, right?
Yeah. You see the...
but not all of them, no?
No. Mm-hmm. And there's a radio opaque marked that actually separate the umbrella and the cover. So maybe we should pull back the whole system and then redeploy it more proximally.
Mm-hmm. So I pull back and start about here.
Yeah.
Let's give a little puff.
Yeah.
A little bit more, huh? Like this, huh?
Yeah.
Horst, could we
so I'm
ask?
exposing a little bit.
Yes.
Yes, go ahead.
Maybe Yajin could speak, but he was obviously unhappy about something, but it's not clear from us what he was unhappy about.
Yeah, keep pushing.
I'm rotating counterclockwise. We will explain in a second.
Yeah. Yeah, that's better. Yeah, that's nice.
I think why you were not happy about the umbrella not fully opening, is that correct?
Yes.
Previously.
Now it's very nice. Now it's fully opened.
Okay, so let's go back to the cine run before. Oh. No, before was this one.
Yeah.
Okay, can you explain what we didn't like?
Usually you see there's tiny radio opaque dots in the umbrella. It signifies the lower end of the umbrella. When it fully opens, it should be at the same level as the radio opaque mark.
Can you use the cursor at all, Horst? It's an important point.
Our cursor here is the Philips cursor,
Is
which
there
is
a cursor?
Oh,
well, there's a
we can
cursor,
show.
but we have to.
So just
You have to go to the
clarify that
measurement
point,
modes.
because why I didn't understand.
Yeah, I think that's very important because if the umbrella is not opened properly, the distal end is not really atraumatic because the metal frames of individual frames may touch against the appendage wall.
I don't know whether you can see this cursor.
Yeah, we can.
Okay.
Okay.
Yeah.
So I think this strut here, that is looking good, right?
Yeah, but
the others are not in the same line, so some of them are distorted. Would you like to point it out?
Okay, let me try to use this.
It's a very small joystick.
While you're doing that,
you see this, well, actually the most important thing is this radio opaque mark here that connects the upper part. This part is the umbrella, and then, it's very difficult to move. And this part is the disc. If the umbrella is fully opened, it will roll like this. It will claw, and then it goes
George
down.
Nikinik, are you?
Goes down
Yeah, and,
here, and then the radio opaque mark here will be at the same level at here.
Okay, now show us the current view.
Okay.
And explain that again.
Can you stop the
George?
measurement? Let me forward it first, right?
You see these tiny dots are actually coming down.
And now all of them are coming down.
Yeah,
This
but
is the
not
difference.
yet the radio opaque mark is coming out yet. And then you have to keep pushing at this juncture. I don't know if you can notice there's actually a radio opaque dots inside the sheath.
There's
about
too
to
much
come
contrast
out.
in there, but
Yeah.
Let's just move on a little, Horst Dusby. We're quite a bit behind, and we have to get Dr. Nikinik to the airport in time. So.
Okay. So, okay, let this run. You can see again the deployment. Then we switch to the echo. And I think then we are almost ready to release. The echo looks good.
So there was a next run as well, wasn't there?
Now you can see all the, no, this is the
Yeah, it's
current.
pointing down,
All of them
and
are
then you
pointing
see
down.
the radio opaque dots
now we
coming
see it,
out.
yeah.
And these tiny dots actually form at the same line
Yeah.
as the radio opaque dots.
Mhm.
Here, it means the umbrella is fully opened. And the distal end is completely atraumatic.
Okay, got
Is
it.
there a bubble
Switch
there?
to the echo. Huh?
Is there?
Is there what?
Bubble.
Bubble.
Bubble?
Where?
Well, I asked
Yeah.
distal appendage.
Yeah, there's an air bubble. You see that?
Right, yes.
Yeah. Okay, we'll stay there. Okay, let's look on
Well
the echo.
spotted.
Okay, so echo here you can see that the device looks lovely in the 45-degree view, nicely sitting at the lobe level where we want it to be, most of it below the circumflex vessel. You can see that the disc is nicely covering the orifice. And then if you look in this 1-5 view, the orthogonal view, what you see is obviously the lobe has been deployed in the superior lobe of the appendage, and you can see the disc, and there is a bit of a gap still, similar to before, but much less. But the device does seem to be under tension, the disc. You can see that concavity as well. So if we're happy with that, there is a small gap. I don't think it's fully covering the appendage as it stands. I'm just going to show you a 3D of that as well.
Let's do an angiogram.
And you can just see there on 3D that there is a slight gap at the back there.
Not much on the fluoro.
Very small
Okay.
gap on fluoro. You see
Okay.
that?
Can you make the fluoro big?
Can you show some colour, Bushra?
Yeah, it's much less than it was from previously, but there is a tiny gap that you can just
Yeah.
see around the back there.
Okay.
Okay, but I wonder whether that will disappear once you release
I
it.
think once you release the device, it will disappear.
So let's release now.
Can you measure the diameter of the disc at 135 degree? It just shows that it shortens by a few millimeters.
Yeah.
So I will release now.
And it's just a straightforward screw mechanism, yeah?
Yeah.
Yeah.
Looks like it's up to there. Yeah.
So you see it goes towards the lower end after release. So it means that the inferior gap will be gone.
something is going through, but we don't know whether it's going through. The edge, it lies nicely upon the edge of the orifice.
Does the 3D look any different, Bushra?
Yeah, so you can just about make out the edge, and actually now on release that disc is actually touching the orifice wall there. So let's just check it on 3D.
It looks like an excellent result.
Yeah. The horse didn't check the tuck test, but I presume it is very stable.
Well, I know this device cannot embolize.
Even Maurice is impressed, I think.
Yeah.
So
Maurice?
Okay, so we're going to say, well done, team.
Yeah.
Thank you very much, and move on to the lectures.